Great, thanks so much. It's day 3, and what I'd like you to do is relax your mind and take a walk with me as I take you through a little bit of the things that I've seen growing up, from Nairobi, Kenya, to where I live now in Harlem, New York. I traveled a lot as a kid. My dad worked in agriculture, and along the way we moved from Africa to all over the United States. And I spent a lot of time in places like this that you see, in busy terminals and train stations, and I was fascinated by these places. I loved them. You could rest your eyes and you could just allow the flow of people to come and go, or you could just pay attention to individuals when you were there, and you could just spend time just studying that place endlessly as a kid. And so it's no surprise in some ways that I find myself in a hospital later in my life. These are busy places. People are coming and going in and out of health. It's hard to say where anybody really is in their journey, whether they're going home or they're going somewhere else. And yet we can endlessly measure these places and everything about them, and yet know so little about the lives of the people that transit through them. As we were traveling, my dad would go and spend time in fields. Whether it was in Ethiopia or in the Midwest, where they live now, he would spend time with farmers. And as I learned about his work, I also learned that there was another group of people that were constantly there as well. They were agricultural extension workers. And these were people that essentially came that had either technical knowledge or information about things that farmers would find relevant, new tools, new innovations, new technical advances, and they would go out and spend time with farmers. And at the same time, they would also learn what actually were the issues on farmers' minds, what they were really thinking, what they needed, what they anticipated, and then they would go back and work on the next generation of solutions and then push it all back out again. And what I loved about this interaction was that it was really a two-way feedback system. On one end, you had people that were developing solutions and innovations. And on the other side, you had people that were trying them out, putting them in the context of their own world, a real scenario of really trying to grow things, and then sending the message back and saying, you know, these are or are not working for us. Maybe you're not even looking at the right problem. And these extension systems are all over the world. The United States Department of Agriculture invested in them heavily in the United States. If you go to Ethiopia, if you go to Southeast Asia, they're everywhere. They're pervasive. And one thing I really appreciated from the journeys that I took with my dad was that the way that he considered what needed to be done for a field like this was very different from what a farmer thought about, how he thought about growing or how she thought about growing. And the relationship of the farmer to what they were growing was different. It was intimate. They worried about the soil. They worried about the soil not only this season but next season. They worried about the nature of these crops. They worried about a whole set of things and they also celebrated a whole set of things that were part of the culture of farming, that the extension worker and then even one layer up in the systems that kind of built solutions never really appreciated. So again, it's really no surprise that later on in my career, over the last 10 years, I've spent a lot of time building extension workers for health. This is Southeast Uganda, where you see a community health worker walking into a lush area where bananas are the most common crop. But what she's doing is she's going into the household and she's going to be talking to the mother and the father about the health of their children, finding out if there are fevers, finding out what other things they need help with, their nutrition status. And then she's going to go back and discuss that with the clinics and hospitals, which are very distant. She forms this critical link between the healthcare system and the community, and really this two-way feedback loop. So over the last 10 years, I've been working with the economist Jeffrey Sachs to build the investment strategy for these systems across sub-Saharan Africa. And elements of them are quite technical. If you look at this schematic diagram, you see that a health worker is able to interact with a mother and their child, but also is equipped with a mobile phone so that they can get help. They can, like Foursquare, check in where they are geographically. They can note symptoms. They can deliver supplies and automatically know that the supply chain has to be replenished. They carry rapid diagnostic tests, so on the spot, they can find out if a child that has fever has malaria and whether or not they need an anti-malarial. They're equipped and trusted with specific and trained protocols that allow them to give curative medications, anti-malarials and antibiotics when necessary, and it's absolutely critical in these settings. But that's not their whole function. I remember walking into a household in Uganda with actually that health worker that we saw earlier, and we had asked the mother how many children are in this house, and she said that there were 4 children. And we counted the kids, and there were 5. And we said there looked like there's 5 children. And she said there's 4. But he's epileptic, is essentially what we understood. And she didn't really count that 5th child actually as really in the same category as those other 4. And you realize very quickly that you can be entirely blind to what's taking place if you just simply don't go there, if you don't walk to places and have some sense of how people think about their life, their community, and how they convey information to you through the strained aperture of a clinical visit or in a hospital. Over the past years, this work has expanded enormously, and the sophistication of these systems, as I mentioned, with mobile phone systems, management systems, financial infrastructure, rapid diagnostic tests, has grown immeasurably. I lead the 1 Million Community Health Worker campaign for the African Union, which is hosted by the African Union. And you can imagine in the western part of Africa now, where you see the red parts are, of course, areas where it's very long time to get to a market. And of course, the Sahara is one of those places. But if you look right below the Sahara on the western side, you see Liberia, Sierra Leone, Guinea, Nigeria, Senegal. Areas where Ebola is currently moving rapidly, out of control, and very fast. In these settings, it's been more urgent than ever to build these type of community health worker systems, especially because the trust between traditional healthcare systems and communities is frayed. You don't know what's going to happen to you if you take somebody who you think might have Ebola into a hospital. The stories of quarantine are frightening. And to be able to have this link of somebody that's able to extend, who's a part of that community, who lives there, that's able to explain what's going on, to able to walk with you and explain, what is the relationship here and actually provide and do things for you is incredibly important. And our team is now leading a large surge of health workers across this region. What's critical, and I think what I really appreciated about all of these types of extension systems, is that they're not just delivery links. When you talk about community health workers or people that are working in communities, they're not just there to transmit messages, give out drugs, tell people about how they should be doing things to be healthy. They're also this incredibly important feedback loop, as I mentioned. And so what they're able to do is actually lead a process of systematic goal setting and discovery. They're able to find out, is this a real problem in a community? Have they identified a goal? Do they know kind of collectively what's going on that needs to be addressed that isn't being addressed, and they can discover things that need solutions? It's something that I see oftentimes missing from the systems that we have in the United States. And along the way, you also allow people to measure. You teach communities how to measure where they're going, whether they're achieving their goals. And the things that are kind of cloistered in the hospital systems, these measurements, the technologies, all the work that we do on the back end gets kind of opened up. It becomes more familiar and it helps everybody move forward. And so as I travel back and forth, I always take, a subway back into Grand Central and head on back up into New York City. And the landscape changes rapidly. I'm amidst skyscrapers, take taxis. People don't walk as much. And you can imagine that if you go a bit north into poorer parts of New York City, I live here in this neighborhood, which is Harlem. People don't walk that much and the food isn't great, and habits and culture and behavior around that create a perfect storm where you have, in neighborhoods like East Harlem, the highest rate of diet-related diseases, 2 times the rate of hospitalizations in New York City. And if you take people that are pre-diabetic and diabetic, it's 90% of some of those communities. So enormous numbers. And what amazes me about my neighborhood is that ringing us are 7 incredible hospitals, of which 4 you'll see on the US News and World Report. And in the center of it is this crater of poor health. And so what we usually hear is this story. Diabetes requires major lifestyle changes. Patients are given medication. They're told to increase their activity, their physical, and their diet, and they have to monitor things carefully. We're also told that clinicians don't really have time, and they're not often trained to influence behavior, and that actually it's a very complex world out there, that socioeconomic factors and cultural factors are actually the major drivers of illness. So what do you do? And so we've built an array of texting applications of care coordinators and managers that stand inside the hospital and that try to do some sort of outreach into these settings. What we've tried to build instead is a social enterprise in Harlem called City Health Works, which essentially is linked to both the clinics as well as embedded in the housing and the neighborhoods of Harlem. And everybody's connected by a lot of the same mobile systems and protocols and techniques that we developed abroad. And so what you see is a strong relationship with primary care, but at the same time, a real embedded sense of this extension system in the housing and in the neighborhood. And what we're discovering is that there's entirely new challenges, things that are not secondary or just an aside, which they seem like when you're in the clinic, but are actually directly important to how people think about their health and what they can do about it. We find that literacy is much lower than we imagined, that rates of trauma are much higher than we imagined, and in fact, they talk to their peers, their health coaches, their community health workers immediately about this sort of thing. And financial challenges are complex, and they change the calculus of what it means to be healthy. At the same time, we also find just an immense number of caregivers in the neighborhood that are already doing the work that we think is essential. We find that there's other sort of assets, faith, stories, ways that people kind of rally themselves in a community setting to accomplish goals. And a lot of these things are basically untapped or unharnessed. We're also doing something that we're trying out now, which is we're also giving people ways to measure, ways to visualize information, ways that they can start to see whether or not there's progress being made in their setting, in their community. The same things that we do in sub-Saharan Africa are being now transferred into settings like Harlem. Of course, the question arises in America about financial sustainability just as it is abroad. So we're working now to build up the evidence for this sort of work across the Innovation Center at the Center for Medicare and Medicaid Services, with the Patient-Centered Outcomes Research Institute, with the Department of Health, and also with other health insurance companies to develop the pricing for all of this work. It's very important, as I've seen, not only to appreciate the work that community health workers or coaches do in the community, but actually build livelihoods for them. Make sure that there is actually a financial path to sustainability. And this requires a lot of work across a whole range of people and different groups. And along the way, we're thinking about the new technology environment that's needed to really support coaches, to support caregivers in the community where they are, and allow that to actually shape and feedback the type of technology development we do in amazing places like this that actually are relevant in people's lives. And so I'd kind of end with having you think a little bit about architecture. I always love walking across this bridge in New York. It's Brooklyn Bridge. And we often think so much about the architecture, the systems, the technology and innovation that goes into something like this incredible structure. But ultimately, bridges don't have anywhere to go. It's the people that cross them that do, that are either returning home or going somewhere to discover something new. And I think ultimately we spend a lot of time thinking about the bridge and not as much time thinking about the people that are crossing it into better health, potentially out of health, and wanting to come back. And so with that, I want you to visit New York. I welcome you. Come and visit us at City HealthWorks in Harlem, and I'm really looking forward to meeting you. Thanks.
Great stuff. What is the importance of big data and the ability to map as a way of convincing people to make community-wide changes? And how have you seen that in practice?
I'll give you two examples. One is that it's been incredible to see people that have no background in healthcare that end up just seeing a map of their community where they see colored dots where symptoms are coming up, whether it's diarrhea or coughs or fevers. And people start to generate their own stories that fit these patterns. Maybe if you see diarrhea clustering in an area, there's maybe something's wrong with the water. And people start immediately thinking, what can we do about the water? I didn't know there was a link between these two things. And people generate both stories and solutions that you really couldn't imagine. In the US, we end up seeing that people start to actually visualize relationships between their housing, with how much they can walk, with their physical activity and chronic illnesses, for instance.
And they stop thinking of themselves in just, I'm me in my apartment, period, the end.
It gives you a sense of being part of something. And data is one way to do that. And I think visualizations are incredible ways to give people intuitive views into it. They may not make the same sense of it that an expert may, but they come up with pretty incredible ways to make it make sense.
There's a great contrast between what Dr. Katz was talking about and what you're talking about. How do community workers, in your experience, achieve the kinds of behavior changes that Dr. Katz talks about in such a very kind of commercially sort of pleasing way, but may not necessarily be persuasive in a housing project in East Harlem?
I think one is that we almost expect there to be some magic, that if we send out somebody who's from the community, they're talking to somebody else, they'll create change. But you actually have to equip them with skills to be able to do that. One of those skills is motivational interviewing, a type of cognitive behavioral therapy, problem solving, that people learn through role playing. And in that setting, they really learn how to take people's natural instincts, their positivities, their negative reactions, and then turn it into things that they can use to move forward a conversation with somebody. And so I think what I like, what you see is that there's both something very concrete about the skills that they have, but they also are really well-versed in how to not be unfazed by the things that they hear that may be kind of a little bit too much or too complicated for people that are unfamiliar.
So just to translate, you're really seeing change in communities. You're not simply seeing maintenance of chronic conditions.
That's a great way to put it. And I think that's ultimately what is the most interesting. I can't imagine a scenario where as a doctor I spend 20 years giving the same advice to a community. That strikes me as a failure of the highest order. We should be advancing and evolving what we're speaking about as a community conversation. People should be learning, and there should be a way that people are just getting smarter and more sophisticated. It gets imbibed into a culture. That's not happening. We're doing something terribly wrong.
Well, it's great to hear you talk in those terms. Let me get some questions here. What are your thoughts on educating families of diabetics, creating a supportive community around the patient, and proactively addressing future type 2s, particularly children?
This is something I think it's a wonderful question, and I think one thing that's been incredible in our neighborhood and work I've also seen abroad, is that kids are incredible vectors of change in their house. If you end up teaching a kid how they should be thinking about the world, how they should be eating, how they should be moving and exercising, they end up bringing in change into the household in a very different way than anybody else can. And so, I think being able to couple school education and what kids are taught about diabetes, obesity, and living well has a incredible impact, and we're starting to see that happening across the country.
So diabetes coaching and treatment and prevention is actually a vector for all kinds of health changes throughout the family and community.
Absolutely, and kids aren't always your first thought about who to come to when you're thinking about it. But they're incredible ways to do. They're
That's great.
Incredible motivators of families.
What advice do you have for health workers, for other health workers, maybe some in this room, to build trust and empathy with those he cares for when they are so different from himself?
I think that one myth is that you have to be the same type of person, demographically as another to kind of really connect. And while that may be important to some degree, we are all so different that we don't always necessarily even connect with somebody that appears to look like ourselves. But I think ultimately, spending 5 minutes of being deeply engaged with somebody, being interested and curious about them as a person, ends up being a core technique in being able to actually motivate and have them change their perspective on things.
Empathy
Building that
is
rapport.
natural. Empathy is natural.
Absolutely.
Dr. Singh, thanks so much.
Thank you. Thank you.